So, good evening, everybody. I am Dr. Swaraj Bhattacharjee, IZOC Honorary General Secretary, welcoming you all in Eastern India Journal Ophthalmological Congress ARC webinar. This is the webinar that has been brainchild of our President Pranab Ranjan sir and the ARC Chairman Dr. Chingsui Miti. Here we are trying to cover each and every important topics of the ophthalmology, particularly for the general ophthalmologists and postgraduate students. We have already done a few, and today's topic is very important, is OCT in glaucoma diagnosis. And we had our speaker, none other than Dr. M.A. Akbar from Bihar. We had our moderator, Dr. Prashant Srivastava from Kolkata, and the panelists, Professor Fani Sharkar from Agartala, Tripura, and Dr. Rita Das from Bhubaneswar. We had some of our postgraduate students, they are also joining. And with this, I welcome everybody and request our president to give the welcome address. Dr. Pranab Ranjan, sir.
Thank you, Dr. Swaraj Bhattacharya. It's a huge pleasure for me to welcome you all to the AIZOC platform and the Academic Research Committee under Professor Y.C. Matty has been doing a phenomenal work. Ever since I took over as the president last year, November, it has become a regular feature, and it is really very, very good in the sense that the postgraduates, the general ophthalmologists are going to benefit a lot. So today's topic is OCT in glaucoma, a very interesting topic in the sense it's a confusing topic also and interesting as well, because glaucoma diagnosis with OCT, perimetry and all other things combined together, Dr. Akbar is going to make our things very clear today. So speaker for today is Dr. M.A. Akbar. He is a fellow from Arvind Eye Hospital, Madurai. The session will be moderated by Dr. Prashant Srivastava, and in panel we have experts like Dr. Rita Das and Professor Fani Sarkar. And in the residents, we have residents from institutions from the East and beyond. And I'm really thankful and grateful once again to Professor Y.C. Matty, he is the chairman ARC, to Dr. Jayanto Barua sir, who is the president-elect, Dr. Lobsang, Dr. Sunil Surana, the joint secretaries, and Dr. Swaraj Bhattacharya and Sabyasachi Patnaik, the chairman scientific committee, for their commitment. With these few words, I welcome the audience, welcome all of you to the AIZOC platform. We will have a great evening of discussion, information tonight from Dr. M.A. Akbar. And fortunately, M.A. Akbar and myself, we have worked together for some time. He's a fantastic, he has got a lot of knowledge and in-depth into glaucoma, so we are going to benefit a lot. With these few words, it's over to the chairman, Dr. Y.C. Matty, Professor Y.C. Matty. Over to you, sir.
Thank you so much, President, sir. And very good evening to everyone present here. Without delaying much time, let me go to the introduction of our respected moderator of today's webinar. He is none other than Dr. Prashant Srivastava. Who has done his MBBS from Burdwan Medical College and his MS in ophthalmology from MKCG Medical College, Berhampur, Odisha. Dr. Srivastava has done his fellowship in glaucoma from Shankar Nethralaya, Chennai, and he has worked earlier as consultant in glaucoma services at Shankar Nethralaya, Kolkata, and also BBI Foundation and Netralayam, Kolkata. Presently, he is working as director of Puspanjali Eye Care in Kolkata. Dr. Srivastava has had various presentations at the state journal and AIOC levels. He has been the invited speaker for All India Conference in 2020. He has also been the invited faculty for Kolkata Academy of Ophthalmology in 2019, GSI in 2021 and 22, and the Ophthalmological Society of West Bengal Conference in 2022. Dr. Srivastava has a publication in of a case report in the Clinical Experimental Optometry Journal. Welcome, sir, and over to you to kindly go ahead with the session.
Thank you so much, sir, for a nice introduction. And thank you, IZOC, for giving me opportunity to moderate this session. So without ado, I would like to introduce our panelists first. So we have two esteemed panelists. First, Professor Fani Sarkar, we all know him very well. He's a professor and head of Department of Ophthalmology in Agartala Government Medical College, Tripura. And he's a wide range of experience in glaucoma, cataract, and medical retina. We all know him for his the kind of good work and the immense knowledge that he has. Our second panelist is Dr. Rita Das. She is a senior consultant and ophthalmologist in Manipal Hospital, Bhubaneswar, with 28 years of practice experience in corporate multi-specialty hospital and research institutes, and also in medical college. She is specialized in advanced cataract surgery and glaucoma. She is a faculty speaker at All India Ophthalmic Society for last consecutive years and instruction course. She is a faculty also in Glaucoma Society of India in 2014, 17, and 18 programs. She has held multiple national and state conferences, presented papers and videos in AIOC, GSI, and Odisha State Ophthalmic Society. She has demonstrated surgery in multiple workshops, performed postgrad teacher as MS Ophthalmology series guides to DNB students. So with that, I welcome both the panelists, and we'll start the session. So today, our topic of discussion is role of OCT in glaucoma. So already our speaker, Dr. M.A. Akbar, has been introduced already. So we'll go straight away and start. I request Dr. Akbar to share the slides and start the discussion.
Right. Is it?
Yes, sir. Slide visible. Yeah.
Is audible?
Yeah. You're audible.
You're audible, sir. You're audible.
Okay. So first and foremost, thank you, Pranav sir, for very generous words for me. But we are still very, very small in front of your huge experience of glaucoma. I would like to thank Professor Mathai sir, who has actually contacted me over phone and given me this generous opportunity to present this topic in front of all of you. And also Team EIZOC, its chairman, secretary, and ARC. All of you, thank you very much. And without much ado, let us start the topic. So today my topic is OCT and glaucoma diagnosis. So so there is no financial interest and long course of learning. So I have learned a lot from so many people. So my courtesy in front actually, and I have actually taken so many slides from some of those people. So my sincere thanks to them. So in market, we have so many OCTs. What we have to remember, two things about these machines. First thing is all these machines, and when I'm talking about machine, I'm only talking about a spectral domain. Since we are not using time domain anymore, we will stick our topic to spectral domain OCT, mostly of cirrus. And if to explain some of the stuffs, I would take help of RT view or spectralis. So while knowing about the machine, we have to remember two things. First thing, almost all these machines have similar results in sensitivity or specificity. So you can use any of the machine. And the second point, the most important to remember is never compare one result of one machine from the result of other machine. Since all the machines have different normative data and they have little different softwares, so the results from one machine should not be compared from the result of the other machine. So the aim of my talk would be today to interpret the printout correctly, and then to find out if there is any mistakes or if there is any pitfalls or variations, and also to correlate clinically with the optic nerve head and RNFL, and if time permits, little about Hood report also. So while making it clear, I would also like to tell that I will not be going much into the theoretical part of the OCT because with the stipulated time, let us understand the printout and the variation in it. So why OCT? Again, we know from our theoretical background that before any visual field starts, can my cursor is shown there?
Yeah.
Okay, fine. So,
yes, visible, sir.
Okay, so experience the power failure at our place. So a lot of power failure here. Anyway, so this is the visual field And the fall of visual field is actually quite delayed as far as the fall of RNFL is compared. So before any visual field defect comes into play, there is already 35 to 40% of RNFL is already lost. So if there is any modality in which we can get to know the loss of RNFL, we can actually have a very good time lag in our favor to manage the glaucoma. So we can have a head start actually. Now, as we know that the basic pathology is actually the loss of ganglion cell, and the axons of the ganglion cells actually form the nerve fiber layer. So that is why we actually have a macular scan, which actually calculates the ganglion cell complex, and we have an RNFL evaluation. Also, clinically, we see that there is so much of notching, thinning, and cupping into the ONH area, and that is why it is imperative to evaluate ONH also. So in glaucoma, we have these three evaluation actually: RNFL, optic nerve head, and macular ganglion cell complex. So let us do one by one. Again, this is a theory part. I will just mention in brief that in spectral domain OCT, the only change from time domain OCT is actually fixed reference mirror. And because of this fixed reference mirror, we actually can take very multiple scans in very minimal time. So as we talk about the RNFL scan, machine actually scans a circumpapillary 3.4 mm circle, which with so many A scans. Now the number of A scans and the B scans which is there in the machines, which is actually progressing in a sense that in the time domain it was very few, and as we are going into further generations, the speeds and scans of the number and speed of the scans are actually improving very much. Now, how does machine do it? So from temporal, it actually starts scanning from temporal to superior to nasal and then again inferior. And that is how a complete circle is completed. About optic nerve head analysis, machine takes a B scan in a vertical section and also into or a horizontal section. And after taking this section, we extract a horizontal tomogram and a vertical tomogram. Now, this based on this horizontal and vertical tomogram, what machine finds is bone marrow opening. Brush membrane opening. Brush membrane opening, and the end of the brush membrane opening is actually considered as the disc margin. So this is the disc margin, and the internal limiting membrane end is actually quantified as the cup margin. And the minimal distance from this BM opening to the internal limiting membrane is actually give us what is called minimal rim width. In the macular scan, as it is already mentioned, machines actually scans the ganglion cell, and along with that, the axon of it, which makes the RNFL, and the dendrite of it, which makes the inner plexiform layer. So these three layers are actually evaluated in case of OptiView, and only GCL and IPL in case of Cirrus. And again, both machines, it's actually similar in their results, but one cannot be compared. One result cannot be compared with the other. So macular scan has different software. It is actually a 6 mm into 6 mm cube, and you have different scan software. So now we will come into with this small introduction about the type of the scans. Now we have actually come into the scan proper. So this is a normal Cirrus chart look like. On top of it, you will have patient data and signal strength. So let us see one by one. So this is a normal, not normal, this is a standard cirrus, OCT, ONH and RNFL chart. And it will have so many different compartments, which actually gives a different interpretation and results. And we will go one by one. So on top of it, there is patient data. So age is very important because we know that machine has a normative data, and this is actually age match. It has to be age match. So a correct age of the patient is very important because machine will compare this patient's this age group patient with the normative data of that age group. So correct age is very important, and also the refractive error, because again refractive error normative data would be compared with those refractive error normative data patients. The second one is signal strength. So again, if you have a bad signal, it is good to not to consider these results. So in cirrus, we have signal strength. We have to consider more than 6 as a good signal strength, and in spectralis it is more than 15, and in RT view it is more than 30. Now this is the RNFL thickness map. Now this is the very important map, because it actually gives you the actual thickness of the RNFL of that patient. So it's a kind of raw data, and from this data we actually extract all the other data. So this is very important, and we have to understand its clinical implication also. So the color coding here is a little different than other colors of this chart. So here the hotter colors are actually thicker, like red and yellow are considered as thick, whereas green and blue are considered as the thinner areas. The next is deviation map. So as the name indicates, it actually shows how much patients RNFL is deviated from age match normative data, which is already fed into the machine. So if whether it is similar or whether it is deviating. So color coding here is little different than compared to RNFL thickness map. Here actually red colors is thin RNFL. And if we take it, if we take this circle and cut it open and spread it linear, then we will actually extract the RNFL circular tomogram. And from this circular tomogram, all other data are actually extracted. So again, these are very important maps. Now then comes RNFL thickness map, and classically it is as I've already shown how the machine scans. So from temporal to superior to nasal to inferior to temporal, that is also called T-snet map, and that is how RNFL is actually calculated. Now in a normal patient, both the green is actually normal, and that includes 95% of the population, and yellow is actually 5%, and red is only 1%. So anything falling into the red area is actually only 1% of the population will have such normal value. So it's very likely that it is actually abnormal. Likewise, we have T-snet graph of neuroretinal rim also. In RNFL, we have a double hump pattern because we know that superior and inferiorly RNFL are thick, and that is why we have a bi-hump appearance. In neuroretinal rim, we actually have the same color coding, and the bold black line actually shows the right eye, and the dotted line actually shows the left eye. And then you have RNFL, quadrant, and clock cover. So these are again the RNFL, which is expressed in the quadrant and also into the clock cover. And the probability of these colors actually shows whether they are into the normal range or into the thinner zones. Now this RNFL circulation, circular tomogram, as I already mentioned, that this deviation map, if you cut it open and spread linear, we will get the RNFL circular map, and all the other data are actually from this map. So we have to see this scan very specifically, because even with a good signal strength, if there is any segmentation problem, there could be false positive or false negative results into the chart. Now, as I already mentioned, this deviation map plots the RNFL, and from this, all these data are actually extrapolated. Now, these are the key parameters. So we have 7 key parameters in Cirrus, like average thickness, RNFL symmetry, and then disk area, cup disk ratio, and all these. And machine also has a normal range from where to where it considers normal, and below which it will consider abnormal, and depending on whether it is in the 5% population or 1% population, it will mark it as a yellow or red. Now about macular scan. As we have discussed it already, that nerve fiber layer, ganglion cell layer, and inner plexiform layer, they make ganglion cell complex. And OptiView measures all these 3 layers, whereas the Cirrus measures only ganglion cell and inner plexiform layers. So this is a complete chart. This side it is RNFL and ONH, and this side it is ganglion cell analysis. So likewise, here also you have on top a patient data area. So again, you have to correctly enter the patient age. Also, you have to see signal strength, which should be more than 5 or more than 6. Now, this is the thickness map. This is a 6 into 6 mm area, and each and every point is actually scanned, and a thickness map is plotted. Now, here, as in case of ONH and RNFL, the hotter colors are actually thicker and the cooler colors are actually thin. And this is the deviation plot, macular deviation plot. As in case of ONH, again here, this data is actually compared with the normative age match data, and it is seen whether there is any deviation or not. So like in this case, if you see in the thickness map, this is actually thicker area, and this cool area, the blue area, is actually thin area, which is actually shown very beautifully as a red, which in case of deviation map shows a thinning in the macular deviation map. Here also we have some parameters, like as in case of ONH and RNFL. Cirrus here has a special parameter known as minimal GCL, whereas Avanti or OptiView has GLV and FLV. I'll come to it just in a short while. Now then, this is a horizontal B scan. It is simply a macular scan. And again, here segmentation, to detect the segmentation is very important. We have to see whether the segmentation is correct or not. Say in case of diabetic macular edema, or say ARMD, or pathological myopia, ERM, actually the results get changed and we can have error into the result. Now the focal loss volume is actually the focal thinning or the isolated thinnings, whereas the global loss volume is actually the overall thinning of the GCC. So if we compare it with the Humphrey field, this is something like pattern standard deviation, and this is something like mean deviation. So an overall thinning and focal thinnings. Now, based on these interpretation, now let us see a few of the charts actually. So this is one chart, and we have to evaluate whether there is an RNFL defect or there is no defect in this chart. So we see that this is the thickness map, and we have some yellow and red color here, and likewise here also, but it is asymmetric. See, this is quite thick and this is quite thin. So there is some asymmetry in the thickness map. That is why thickness map, the raw data, is very, very important. Now, in the deviation, and this is actually corresponded into the macular scan actually. So this thinning, we can have a wedge area. We can actually see a wedge area. I am not sure whether it is visible or not. Let me show this. So there is asymmetry here. There is a wedge-shaped area here, which is actually corresponding to the macular analysis. We can see this red thinning here, and this also corresponds to the neuroretinal RNFL thinning here, which is coming into the red zone. So if we see everything, signal quality is 62, so it is more than 40, and there is some asymmetry here. There is wedge defect here, which is corresponding to the macular scan, and then there is RNFL thinning here. So if we take everything into account, we can confidently say that this patient is having a glaucomatous defect and it's progressing into glaucoma. Now, what do we say about this? So suppose we compare these two charts, these two eyes actually. So we see that right eye is actually the butterfly pattern or the hourglass pattern is actually following. But if we see the left eye, it's quite thin actually. The hot colors are actually gone. So this looks like the RNFL is lost significantly actually. If we see the plot of deviation map, all red and yellow. So it's all the hot colors which showing it's quite thin actually. Probability 1%. Fine. Then we see RNFL. RNFL is also thin. Left eye is the dotted left eye is actually coming into the red zone, which is actually into the 1% zone. And if we see the quadrant hour and clock hour, it's all red zone. So this is all red. So it means it is showing RNFL thinning. But is it glaucoma? And that is why we also say that do not treat the color, treat the glaucoma. So we should not always be seeing the colors, but should also be seeing always see the disc. And if you see the disc here, actually there is a pallor of the rim. And that is why everyone who has practiced glaucoma would say you that never diagnose a patient of glaucoma with the help of only OCT or only visual field. We must examine the optic nerve head, the RNFL, and that too in a dilated pupil. Now, let us see some variations and pitfalls while interpreting the results of the OCT. So this is a classic blinking artifact actually. So if we see these two right and left eye, we can see that there is some loss. There is some loss here because there is a split into the RNFL. So, and that is actually demonstrating into the wedge defect here as a red zone. Here also we can see that there is some thinning here. But if you see this area, This is because of the blinking. So this actually accentuates the glaucoma. So maybe an early glaucoma would be diagnosed as a severe glaucoma based on only the parameters and the RNFL graph. So we have to see in total, and that is why deviation map, which we often tend to forget and only concentrate, mostly we concentrate onto the quadrants and the RNFL thinning. This data is actually very, very important. So in such charts should not be accepted, and we should order a repeat test. Now, this is because of the motion artifact. So this patient actually has a very good signal strength. The signal strength was 8 actually, but when you see the deviation map, you can see the vessels, but see the vessels is actually, the continuity is broken. The continuity is broken. Here also the continuity is broken. Continuity is broken. So what has happened is the machine actually started taking the scan of the ONH, and there is a sudden movement of the eye. So some area it has actually measured the in and around ONH, and there are some areas which is outside of this zone, and that is why again we should never rely on such results. Now this is very interesting, the floaters and other vitreous opacities. Now let us see with this example. Now this is a very nice article, and what the researchers have done is they have taken a patient who has vitreous floaters, and they have taken serial OCT monitoring at different interval. And based upon the location of the vitreous opacity, the plot actually got changed. So this area in the deviation map, it was away from 3.4 mm. So all the quadrants are normal. See here, half of the opacity has actually come into the scanning zone, and that is why there is a borderline defect. And again, this black's actually showing the deficiency here. Now, again, the whole of the vitreous opacity has come into the scanning zone, and then it is showing as a red defect. So based upon the vitreous opacity location, if it comes into scanning zone, there could be various interpretation of the maps. So again, seeing the total thickness map, seeing the deviation map is a must, or else we will be treating only the colors and not the glaucoma. Now this is about circular tomogram. As I said, it is a very, very important parameter, and we have to pay a keen observation on this parameter. See, now there must be how machine does is it boundary the RNFL with one line above and one line below the nerve fiber layer. So if you see this chart, see RNFL. If you see this point, it has actually come below. If you see this point, it has actually come below. So the segmentation is not proper because of any reasons. So we will not again consider such graphs. This is because of the opacity, like vitreous opacity, asteroid holosis. So you see this shadow. So basically machine is not calculating the RNFL of these areas. So these are unscanned areas, and again machine will interpret, in a gross case, it will interpret it as a thinning. Now see, this chart is not actually clear, but actually I want to make only one point here. See, in the RNFL, it has come to actually the base, the 0. So there's something called floor effect. So even in case of say 100% optic atrophy because of glaucoma, the RNFL will not go to 0 because there will be still some glial cells and nerve vessels which will be there. So it will have a effect. It will have some thickness. It cannot go to 0, and that is called floor effect. So if you have something like this, again discard this chart and order a fresh report. So this is again because of the opacity. So I'm just showing you the variation where we have to pay attention and we should not consider such reports. So see this, there is a opacity because of which this area did not got scanned, and in deviation map it is showing as thinning. Also, because this has come into the disc area, the measurement of disc itself is not correct. And again, as I mentioned, we have a floor effect here. There is no RNFL measured here and is showing as a 0. So again, we have to be very careful. We should not consider such reports. Do we have some time, Prashant?
Yeah, go on.
So there is something called Hood report, and this is a new addition into the Cirrus OCT. The Topcon and Zeiss have actually incorporated, and it has given us a good.
Airport?
Yeah. It has given us a little different approach or different view as how to see the damage. So they have basically made 3 changes based on
Swaraj,
their.
sir, can you unmute your system?
So what they say is the concept of macular vulnerable zone, inferior vulnerable zone, and superior vulnerable zone, and they say the inferior ganglion area in the macula is actually more prone to damage, and it actually enters into the inferior temporal quadrant of the glaucoma of the optic nerve head, and also the inferior and the superior, because all the nerve fiber layer come and enter into this crowded space. They are actually the vulnerable zone, and they have actually changed from T-Cint map to NS-TIN map. So what they wanted is they have kept nasal there, and superior, then temporal, and then inferior. And based on that, and also they have incorporated the visual field also to show that there is a functional correlation. So there is a loss, and there is a functional correlation also of that loss. So that is Hood report, and it actually gives some good values to our armamentarium of the glaucoma report. So thank you very much.
Thank you, Dr. Akbar. Such a great talk, and I think we have covered everything about the OCT in macula. I myself have few doubt about the things that we'll discuss.
Yeah.
And apart from that, I think we can take questions from audience if any, and or we can discuss. We still have time. We have around 20 minutes now, so we can discuss more and more about OCT in glaucoma. This Hood report particularly is a feature of Topcon, or it's there in the Zeiss as well?
They have incorporated in both, in Zeiss as well as in Topcon.
So basically, it says that if
actually just day before yesterday, Topcon people had come to me and they said, "Sir, please purchase our new Topcon machine. We have incorporated Hood also into it."
So basically, it correlates the RNFL with the macronic ganglion cell loss.
Yeah,
That's the correlates.
No.
So in our practice, how often we see the macula more than RNFL? Do you see the macular scan in your practice in a clinical scenario where you are seeing day-to-day patient? Do you see macular scan and you see RNFL both together, or just first you see RNFL and decide?
No, Dr. Prashant, the machine which we have, I am in a rural town of Bihar. The machine which we have is an older machine, and it does not have much of macular scan actually. So right now I am only seeing the ONH and RNFL. But the newer machine all the newer machine have this, and if we take incorporation into it, it will, as we said, no, the ganglion cell will be lost quite early actually, because in the macula the ganglion cell is 6 layer or 5 layer thick, so the loss will be picked quite early actually. So it is always good in the early glaucoma where we have suspicion or suspicious disc. It is it's a very good practice to go and see the macular scan, because there we can find the defect a little early.
Yes, true. Because
Yeah.
we have
Let me just interrupt, Dr. Akbar. May I request you to kindly stop sharing the screen so that we can see each other's face? Yeah, that will be a better thing for discussion. Please carry on, Dr. Srivastava.
Right.
Please carry on. Please carry on, Dr. Prasant and Srivastava.
yeah, we were discussing that the macula has, since the macula has a redundant amount of ganglionous cell, and the thickness is quite higher, so the loss will be easier to quantify at a very early stage as compared to the loss at RNFL, which will be little later. So if we see at the macula at very details, so it's much easier for us to detect the glaucoma at earlier stage, because the thickness is more, so loss will be more evident as compared to the RNFL. Similarly, any functional loss will be followed by structural. So all the structural loss will be first. So first will be macular. I think Dr. Akbar, it's evident from his slides also, the first loss which will be more evident will be the macular loss, then RNFL, which is followed by the perimetric changes, I think. Right?
Right.
So anything else from the panel? Yeah, ma'am, please.
But regularly we take macular scan and also the RNFL and ONH. All three we take, because though macula detects it's early, but still it 50% of the suppose RGC are there, and rest of the things are in the other part. So what about the rest of the things?
No, madam.
Early diagnosis can be done with macular scan, but we should take all the parameters, ONH and
ONH is a must.
RNFL.
Only thing, if you are suspicious, then it's better to take to map macula also. It is like same, madam, in visual field. Now we order 24-2 and likewise we order 10-2 also along.
10-2 actually, initially we are thinking in advanced glaucoma, 10-2 is required, but at present 10-2 is required for early diagnosis.
So yes, ma'am, something like that.
Yeah. The only problem which I feel in the macula is like sometimes it's the results are very misleading because of the retinal issues and all, which someone has to be very careful. So you cannot solely diagnose on the basis of macular scan. It's very overall OCT could be very misleading if you don't relate it with this picture and the perimetry, more so with the macular scan.
That is why, see, if you have a co-pathology, of retina, it's really a tricky game then, and that is why the segmentation thing come into play. The segmentation, the graph or the segmented plot has to be put a lot of attention actually. From there, all the other maps come, like RNFL, the quadrant, the quad hours, the hours. So the segmentation, the circular tomogram, we have to pay a lot of attention. And also, see, even if I tell you about my practice, in initial days, I did not used to see the thickness map at all. Just seeing the clock cover and then RNFL thickness and signal strength, I used to make a diagnosis. That was the initial days when I practiced glaucoma. But as I started giving my attention to thickness map, I tell you, it's a really most important data of all the OCT. I feel it is a thickness map, the raw data. If you start looking that data and start deciphering the information from it, you will have immense knowledge from that particular data itself.
Very true.
You mean to say the raw data and the deviation chart, which is just below that? Yes, I think that's very critical, and that's, I think, one of the most important things that we have to note. Just I have one query actually. I think, to Dr. Akbar here, the RNFL floor effect that you have said, this probably this is mostly because of opacities in the vitreous or elsewhere. Do you think it is? Is it the cause or any other?
Floor effect, we say, sir, that if in a RNFL thickness plot, if we see that the graph of bold line or dotted line has touched the baseline, means it is 0. But sir, we know that in RNFL you don't only does not have only the neural tissue, but also have the vessels and glial and supportive astrocytes also. So
that point is taken. That point is taken. I'm just wanting to know actually. I mean, what are the basic actually? Why is this happening? Actually, is it because of vitreous opacities or is it because
opacity can also give you a floor effect kind of picture?
Where the scan has actually the machine has failed to actually scan that area basically,
yes,
which gives a wrong information that it is 0 actually.
Exactly.
That's what.
Okay. Exactly.
Thank you. Let us request our Dr. Prasanna. I think you please request our residents who are present here. Dr. Saurabh is there. I think I can see the Christy and then
Dr.
Soumya. Soumya, yes, Soumya has just come on live. You have any queries to the speaker?
My professor used to say, sir, if there is no doubt, it means they have understood all, or most probably,
or they're not paying attention.
Nothing at all.
Sir, I have one question, sir.
Yeah, yes, please. You should have.
Sir, if we get a patient who has RNFL thickness loss, which has been detected by OCT, but there is no significant visual loss, field loss by perimetry, and vertical cup disc ratio is around 0.6, 0.7, then what to do? Should we start anti-glaucoma?
The question goes to Dr. Akbar. Yeah.
So again, say diagnostic glaucoma and then a starting treatment, it depends on multiple factors actually. So if there is a definite defect and on repeated OCTs it is seeing defect, and IOP also on borderline or even in the normal zone, if there is a definite defect, there is no problem in starting the treatment. But again, we have to see so many things actually. Say patient age. Suppose patient age is 80, 85. Okay. And we are just seeing something into the OCT, but their visual thing is all fine. Then it's better to wait. Why to put on medication to such elderly people? And again, but say it's a young person, one-eyed person, then it's better to start treatment. So it's a multiple factor actually. And if the patient is informant, patient is his IQ is good and he can follow up the visits, and you are in suspicion whether to start or not, then it's also a good practice to ask him for a regular follow-up till you are not confirmed. When you are confirmed with the help of your OCT and your visual field, and if you're confirmed, then you can start therapy.
Okay, sir.
What do you say, Prashant?
I completely agree to Akbar what he said, that if you're seeing a patient of 8 years of age and you are seeing a defect in RNFL and there is no functional loss, you can still observe the patient. There is no need to put pressure on the patient to start an AGM. Also, I would like to add one point. Sometimes the OCT RNFL scan is not only because of glaucoma, maybe because of retinal issue. You can have a tertiary branch retinal veins obstruction, and that can lead to a defect in RNFL, which can have a localized defect. With that, those will not progress. So it's very interesting, and it's very important to observe the defects are progressing or not. And if the other parameters like your visual field function and other things are normal, pressure is normal, and you are seeing that no other, so you can observe those patients rather than starting.
Okay, sir. Thank you, sir.
Yeah, I think I totally agree with Dr. Prasant there. You need to actually, when you are in doubt, you need to follow up this patient for a while. There's no harm in waiting for 3 months, and then if there's any sign of progression, maybe you should start thinking about initiating therapy. If it is stationary, maybe you should think about something else. Yes.
Then okay, there is a load of therapy also. Once we brand someone glaucoma, then it's very difficult that someone unbrand that patient too as non-glaucoma. So once it is branded glaucoma, then the load on that patient to put drops for lifelong along with its side effect and therapy cost.
True. Completely agree.
Moreover, patient also become psychology. One doctor has given anti-glaucoma. Now stop again. It is very difficult actually. Sometimes actually, what is the glaucoma? Actually, the glaucoma, those are glaucoma specialists. Actually, sometimes they do our diagnosis. This is a problem. So
Yes.
once you, sir, what you told, Dr. Akbar, that if you start the glaucoma from the somewhere, it is very difficult to stop. Patient will tell, no, sir, he has given me Lumigan. Why should you stop? So this
Yes.
is very important.
Having said that,
Blanket statement that if you don't put the drop, you will become completely blind. आप पूरे अंधे हो जाओगे.
Yeah,
And
yes, yes.
and that's why I'm saying, I keep saying this to my patients. Nowadays, glaucoma is sometimes overdiagnosed than underdiagnosed. We used to
Yes.
learn this in our PG days, it's underdiagnosed. But nowadays, because of the many factors, it's overdiagnosed and patients are overtreated sometimes. Because of OCT also, OCT is also culprit.
Yes,
Uh,
yes. I think OCT is one. I think one of the equipments which is I don't know. It can cut both ways actually.
Yes.
Funny,
Nowadays,
sir.
what? Yeah.
Yeah,
What
funny,
Dr.
yeah.
Yeah,
Please, sir.
what Dr. Akbar told, actually, I give very very much important. That is for the resident. Nowadays, what they do, they don't want to see the even fundus also. Whenever come glaucoma, okay, do OCT and do field test. So whenever see the clinical eye should be developed. You must see the optic disc. You must see the nerve failure. Then you go for the test. Otherwise, unnecessary. Because nowadays resident, what is it? They don't want to see the retina. They don't want to see fundus. After coming, okay, you do OCT, RNFL, and you do field changes. So this is very important actually. And moreover, Dr. Akbar, what he told, it's actually OCT, RNFL, that SDOCT, actually, it is very complicated. But he has made it so simple actually. I have learned many things. Thank you, Dr. Akbar.
Very good talk. Very comprehensive. Pani sir, I would like to know from you, what is your experience? How frequently you do OCT for a patient who's already a known case of glaucoma coming back to your OPD after 6 months? Would you repeat a OCT or just
No.
go ahead with the field test?
No. Actually, every 6 months, what we don't do OCT. We are doing the field. Whenever known case of glaucoma, we do only field analysis. Only harmful field we do every 6 months to see the
And the
progression.
first diagnosis, you have a doubt about, then you do OCT.
Yeah. First diagnosis, it is probably nowadays it is mandatory. So Dr. Akbar and other will agree that it is mandatory now that you do must do OCT, RNFL, and field. These two should be there with her.
Just for the sake of completion, I think this can be. I think Dr. Akbar can also answer, or any one of the panelists or Dr. Moderator. Just for the sake of completion, because we are directing this mostly towards our residents. So I think I think a little word about the entire segment.
One question from my side. Very good evening to all my respected seniors. So, what are the limitations of OCT in patients we are dealing with?
So, all the pitfalls which I said, no?
Sir, in cases of high myopic patients, we can rely on OCT RNFL or not?
No, if see again the problem with the myopic eye is when we scan the patient, the machine takes the analysis of RNFL, ONH, and ganglion cell, right?
Yes, sir.
Then machine compares this data with the normative data. So then there will be problem. If the machine compares this data with the normative myopic data, then it is all right because we are comparing a myopic with a myopic. Now, what is happening and most of these machines which we have now, they have a limited range of refractive error, myopes or hypermetropes. So if it goes beyond that, machine will not actually detect it and it will gives you a false result. You understand? So there is definite limitation in case of myopic because your axial length is elongated, your retina is stretched, so it will be more thinned. But if you compare that myopic with the normative myopic data, then you can have actually some result to comment upon. So yes, definitely a high myopia is a limitation of analysis in OCT. And again, that is why I wanted to tell that your raw data is very, very important there. So you have to monitor your raw data and you have to serial monitor your raw data to see whether there is any defect coming in. So as we mentioned, there's a hot colors. So if you start seeing some notching into that hot color, or if you start seeing some peripheral defects also, remember it is a 6x6 scan and we do deviation map only into 3.45, right? So in such cases like tilted disc, high myopes, we have to see the raw data. Same as also in visual field, raw data in such cases are very, very important.
Okay. Thank you so much.
Yeah. Drishti, also I would like to add just one point. In case of any doubt, when you see that the OCT is not confirmatory, like Dr. Akbar said, in high myopia, it's not very reliable tool, because the database which the machine is having, they have incorporated very less amount of myopic patients in the database. That's why it doesn't give a very good result. And if they had a very good amount of myopic patients in the database, then it would have been reliable. So in case of any doubt, best tool is to have disc picture. So you can follow the disc. Best tool is to assess follow the disc, see whether there is a thinning of neuroretinal limb in the further follow-ups. So that's the best tool for in case of any doubt, not only myopia, in case of hypermetropia or even normal patients also. Disc is the best thing to assess a glaucoma or any disease. I think sir was asking something. Yeah, please, sir.
Trying to, for the sake of completion, what is the take that all the experts here would be having on the anterior segment application of OCT in glaucoma?
So I used only in the institute.
Prashant, so what kind of this thing that you want to offer to the residents actually regarding?
As far as the angle calculation is concerned, I think nothing can replace gonioscopy. As we said, nothing can replace your stereoscopic evaluation of disc. No OCT, no visual field can replace it. Likewise, sir, as far as the angle calculation is concerned, 4-mirror applanation gonioscopy is actually the best thing which we can do.
True. Completely agree with that. I think Fani sir also would agree with this.
What about Madam Rita also? Please give your opinion.
Yeah, ma'am.
Hello.
Yes, ma'am.
Yes. Hello.
Yes, ma'am.
Actually, OCT is very good tool, but it should be correlated with the clinical findings, and the chart should be read in a systematic way. Like sir has already mentioned the importance of the signal strength. Likewise, dry eye, whether cataract is there or not, the clinical findings, all those things should be seen while interpreting and correlating the clinic fundus finding with the OCT and deciding to treat or not to treat. Because artifacts are very important points in OCT, and those should be kept in mind while deciding for treatment. And another important thing is that OCT, we mainly depend on early glaucoma and other things also in early glaucoma. So other risk factors like family history and ocular risk factors, all those things should be considered while deciding for treatment, because it's a lifelong treatment. And what sir has already emphasized, the trauma to the patient once he is labeled as glaucoma. So it should be a comprehensive checkup should be done and should be correlated with the OCT finding. Not only on the OCT basis, the treatment should be given, and artifacts particularly should be kept in mind.
Madam, do you do anterior segment OCT apart from OCT RNFL in your day-to-day practice?
Anterior segment OCT, sometimes when it is required, not in all cases.
Like required in which type of situations, can you just, and this is just for the completion. We have postgraduates here and they need to know what is happening and what can be helpful.
Actually, we have a lot of narrow angle glaucoma cases. Where actually we are mostly dependent on gonioscopy. But sometimes we require anti-segment OCT in doubt whether we want to treat or not to treat. But anti-segment OCT is not with our clinic or in our hospital. That's why we have to refer the patient to outside. So that's why that's a limitation for us. But anti-segment OCT mainly for narrow angle glaucoma cases, we mostly dependent on anti-segment OCT.
All right, ma'am. So anything else we can discuss? I think Dr. Anu Roy.
Queries from Dr. Saurabh. You have something to ask, Dr. Saurabh? I can see you there, and Dr. Anu Rai, and this is for you.
Discuss
Actually, you
anything
have
in the
yes,
basic
anything you can ask the speaker or the.
On glaucoma. So
Yeah.
first OCT, if not any doubt you have, you can ask.
Surely.
Then only this talk will be fruitful. No.
Yes.
Arranging with so many talk. It's only for resident. I mean, mostly for resident.
Good evening, sir.
Yeah.
Sir, is there any gradient system related to the loss of RNFL thickness, so that we can, grade the patient as
Moderate,
he's
severe,
progressing
something like
slowly or far?
Yes, doctor.
mild, moderate, severe, something like we do in the visual field, less than 6 to 12, more than 12 decibel fall. That is what you wanted to know. In
Yes.
case of RNFL. No, we do not have that. There is no such grading system on OCT yet, which can describe it as a mild, moderate, severe. And it has reason behind, because see, you do not evaluate one thing only. So in visual field, we mostly evaluate the decibel fall, whether it is
Yes.
focal or global. But here we actually take consideration of multiple factors. So we see ganglion cells and complex also, we see ONH also, and then we see RNFL also, and then we have different machine, different softwares. So yet far we have not, but there are actually work going on to make an OCT grading system mild, moderate, severe. So far there is nothing available in any machine yet. Prashant?
Yes, yes. There is no grading system. You have to just follow the thickness of the individual patient. Follow the same machine. Don't change the machine. Just you have a parameters in one scan. Keep following the patients, the same patient with the same machine, and see whether it is progressing or not. That's the only way. Otherwise, it won't follow the, as Dr. Akbar correctly said, don't follow the colors. Just it is red or yellow or green, whatever it is. See the thickness, see the raw data, and then follow the patients. It's already been described in his talk in a very good way. So follow the raw data, follow the whole picture, don't follow the colors, don't follow a grading system also if there is any, when it comes in future. Follow individual patient as an individual single entity. That is my take for every patient.
So true.
Sir, like in perimetry, when there is a 20% tissue loss equivalent to 5 decibels, it can be, we can see the defect in the visual field. So like that, there is any criteria so that this much tissue loss can be detected in the OCT or something like that?
Yeah, as I told you, Anu, that there are work going on, but again, in case of visual field, there is a standard, say, range from this decibel to this decibel, and variation is not as much as compared to the RNFL thickness. RNFL is a functional, structural thing. Decibel is a functional thing. So because of the function, it is coming, and here we are directly measuring the structure, and this has lot of variation actually. So if we say 50 micron loss, say we give some numbers, it will be very difficult in interpreting. And again, it's only on RNFL, only based on RNFL. Again, as Dr. Prashant said, no, that you have a BRVO, and then you will have some defect here. Only based on RNFL, we can't detect that. You have ganglion cell complex also, ONH complex also, and RNFL complex also. So based on these three, yet there are work going on in it. And maybe some machine will bring, we are the first, as each and every drug company brings, or we are the first. So it will come, just hold your breath, it will come in very soon, not in a near future actually.
Okay.
I think there's so much of variations in the optic nerve head structure. You have got a tilted disc, small disc, large disc, myopic, a disc with a big crescent and PPA. So it's very difficult to quantify and difficult to judge on the basis of these colors and all. It's always you have to correlate everything together. So I think it's already been described, and he's said don't follow the colors and don't wait for I would say don't wait for even a system comes which will quantify and grade. Don't follow that. That would not be accurate because there's a huge variation in the size.
The thickness would be variable even in age. Age also, even when you compare a child, a 20-year-old and an 80-year-old, there's going to be a variation when they are about normal.
So even after that, sir, we will the landmark statement will remain say after examining the optic nerve head.
Yes.
So,
so one question from my side, sir.
Yeah.
Hello.
Yeah, please.
Yes, sir. We knew that 10-2 was. We just knew that 10-2 was used for the advanced cases, but ma'am said that now only for diagnosis it's used. Why? Why, sir? This is my doubt, sir.
I think Madam Ita ma'am can answer this.
Yeah, madam.
Ita ma'am.
That in 24-2, we did that 6 degree apart. So from center, it's 3 degree and 3 degree, this side, that side. But in glaucoma, 10-2, it's 2 degree apart. So 1 degree and 1 degree. In 10-2, we can pick up the glaucoma early than 24-2.
So yeah, so nicely put, madam. So nicely and so easily put it.
Because it scans the visual field very densely. Simple as that. It's very dense scan, so you will not miss a localized
Yes.
And also, like we usually think that the pattern in which glaucoma visual field defect develops. So we usually think it will have centrocecal and then it will be hemiarcuate and then arcuate. And if that is what, then 24- is perfect thing. But see, there is so many variation. And in suppose a patient which have a central defect, very early central.
Normal tension.
Yeah. So then in 3 degree and 6 degree, you will miss that. But the chance of missing that in 1 degree apart is very, very less. And that is why it is better to order 10-2 also in early glaucoma.
And for the residents, the all green in OCT, as sir already has emphasized so many times, is not healthy. Green can be glaucomatous. So because focal defects, they might give green error. So the residents should be very careful regarding this green disease.
Achha, residents, what are the colors you see in OCT? Yellow, red, green. What else you can see in the OCT RNFL apart from
White.
these?
White, sir, you can say.
White is for?
More than average thickness of the comparing population.
Yeah, that's also there. Sometimes because of drusen and sometimes papilloedema, you will see white RNFL. So that sometimes masks the glaucoma also. Yeah, great answer.
Any resident has seen black spot in OCT for the residents? Any residents?
Madam, in vitreous opacity, any existing vitreous opacity?
Any kind of PVD.
PVD.
Vitreous opacity or floaters, that is already told.
In dense cataract, will you get those things?
No. Dense cataract is central. Image quality.
If some area is not scanned properly, what color will come?
Black.
Ma'am, in dense posterior subcapsular cataract.
Have you seen that thing in any OCT picture? So next time when you're seeing any steroid-induced posterior subcapsular cataract along with this suspect and you are going for a OCT, please look into it. Okay. Always see the signal strength. That I want to emphasize, as sir already has told that thing. And if you're in low signal strength, repeat the OCT. Don't hesitate to repeat. Don't start the treatment immediately. Okay.
Okay.
Thank you. Because glaucoma, everything is bad, but it's slowly progressive. Unless it's a narrow angle or something like that. But other type of, most of the glaucomas is very slowly progressive. Within a month, it's not going to make someone blind.
Yes, yes, it's a slow disease. Dr. Akbar, do you think that we can also do OCT RNFL in a non-dilated people? So what is your suggestion to do it, get it done in a dilated state, or undilated also we can rely on?
Prashant, I always say to dilate and do it.
OCT also.
OCT also, even if there is non-mydriatic, I will also always tell, because it will definitely have convenience, better picture. See, it is not we who are taking most of the time, no, the operator.
Yes.
They may not, they see, we have clinical implication and everything into picture. They do not. So the one we have, it's a non-mydriatic actually, but I always tell you dilate and take. That is my take. I mean, madam, would you agree to this, ma'am, or do you ask for convenience? We can always tell don't dilate and take.
Which one is better, ma'am? Which would you suggest?
The question is to me.
Yes, ma'am.
Hello.
Yes, ma'am. Yes,
I always dilate and do ask for OCT. I always dilate.
Funny, sir, you also dilate always before doing the.
Yeah, dilate. We dilate always.
So it's a consensus that you always dilate and then do the OCT.
What is your take, Prashant?
Yeah, same. Always dilate. You will have more information if you dilate. Your signal strength will be better, like a normal case. So anything else you want to ask? Any small thing also you can ask. There is no problem. We are here to answer anything, any small thing.
And nothing is small. You may be
nothing is small. Nothing is small. Yes, very right.
You may be thinking it's small thing, but sometimes. Sir, when I was doing my post graduation, I was very much perplexed. When there is a defect in inferior retina, how come visual field defect is in the superior area? This was my doubt, sir, when I was doing second year PG, sir.
Well, that I know. That's quite natural. One thing I would like to add here is don't follow the colors, as I said. Just keenly follow the black solid line which shows the patient's RNFL data. Sometimes what happens, you have a OCT which has a localized notch, a very small notch or RNFL defect. The black solid area the line will dip down and come out. If you see the scan as a whole, it will show you green. But you see that there's a notch and the dip will be there right at the point of the RNFL defect. So the result will give a averaged out picture which might be normal, but the patient might be having a very early glaucoma. So black solid line you should follow always, which is represented in the background of age-related patient database.
Quite true. And just wanted to add one more line to it, that say if in RNFL thickness double hump pattern, you are seeing the black line. So the bold line right or the dotted is the left, and you see the say notch into the solid line, then you must look directly to the where should we go? We should go to the thickness map. See the thickness map, and there is one exception to it, and that is split RNFL. So sometimes what happen is, mostly it is like group of RNFL bundle come into superior and inferior poles. But sometimes what happens, these RNFL bundle can come into the group and they do not directly come into the superior pole. Rather, they come into one area of the superior and after little distance to the other area. And when you see, again, you will have a notch, and that notch can actually come to the red area also. But if you see the thickness map, you will understand that it is actually two bundles of the RNFL, which is more beautifully shown in the red free filter.
Do you have any picture of that?
Yeah. I would share that. That's quite actually that's also an anatomical variation. Split RNFL. There you will have notch into the hump.
Thank you so much, sir. Are there any more queries from any of our residents?
Sir, in series we take GC IPL here, and in RTView we take GCC, which include RNFL, GCL, and IPL. Does it make any difference?
Not at all. As far as the sensitivity and specificity is concerned, both are almost similar. The only thing I will again emphasize, when you are taking GCC, always compare GCC with GCC. Don't compare GCC with GCL. Both are similar.
Okay. Sir, if patient comes with flow defect, then how can we follow that patient by doing perimetry?
No, flow defect, as sir already mentioned, I mentioned in my talk, no, flow defect is because of some reason. So most of the most important reason is some opacity, which has actually obstructed the scan to map the RNFL. Okay. So say some vitreous opacity. So that area is not scanned at all. So if you take a scan after some time, maybe the opacity has little moved, or you just tell patient to move his eye right and left, up and down, and then you again take that, maybe that that opacity has moved somewhere else, and then the flow effect will actually go away from that particular area. It may come somewhere else.
Actually,
you
what
can supplement that actually, after having said doing like that, you can do it a very thorough clinical examination, which will, throw up the opacities which you'll be suspecting actually.
Ma'am, you were saying something, Rita ma'am?
actually, mostly Dr. Anu has a doubt regarding that when the curve is in a very lower sector, that floor effect, regarding that floor effect, when the glaucoma is very advanced, actually we do not need that OCT to judge progression. That time we need functional thing like visual field. We do visual field to monitor progression. So when it comes to 30 micron level, then there is no point in doing OCT to judge progression, because there is no other, it is so advanced that no more information will get from OCT. So that time you have to do your visual field or the functional test to judge progression, whether it's progressing or not. Okay, because that time it's very important. Because once 95%, 98% is damaged, the rest things are very important, because once you push a 98-year-old person slightly, he will fall down. But if you push a 30-year person, he will, and he may not heal.
Yes.
So it's very important in advanced glaucoma to judge progression, and progression should be judged from visual field, not from OCT.
Yes.
Like we detect pre-perimetric glaucoma mostly on OCT. The most advanced of glaucoma progression, visual field GPA would be more better suited investigation to follow on.
I think we have come to the end of the session. We have already discussed many good points. It was very interesting and very interactive session, and it is very nice to see the interest of this postgraduate students. I think we had a very nice discussion and many doubts were clear in this session. So I think we can conclude now, sir.
Yes, 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 sir. With your permission, sir, we will conclude. Yes. Thank you so much. I, on behalf of ARC EIZOC, would like to propose a vote of thanks. First of all, on behalf of ARC EIZOC, I'd like to thank our speaker, Dr. M.A. Akbar, for a wonderful rendition
Wonderful
on
talk.
OCT in glaucoma diagnosis. Not only the residents, I think quite a few of us and young ophthalmologists of this thing also should be learning up a few things which are helpful in their day-to-day practice. And thank you so much, sir, for your wonderful and very comprehensive rendition on OCT in glaucoma diagnosis. Also, we would like to thank our moderator of today's function, Dr. Prashant Srivastava, for very nicely moderating the session and making things, the discussion so lively, and for all your wonderful inputs. I'd like to thank also our esteemed panelists, Professor Pani Sarkar and Madam Dr. Rita Das, who have also given so many important inputs and for the lively discussion and their personal touches and experiences. I'm sure all the audiences, including our residents, have benefited from this very extensive discussion that we have had. Also, I'd like to thank our residents today, Dr. Somandev Mandal, Dr. Saurabh Dev from Midnapur Medical College, Dr. Anu Rai and Dr. Drishti Kumari from RIO Patna, and Dr. Sravani Sarkar and Devjit Deka from the Silchar Medical College. Thank you for your interest and thank for the lively discussion that you, the questions that you have thrown up. I hope you have really benefited, and we are so excited that we could be of help to you. We'd also like to thank the EIZOC Secretariat, our President, Dr. Pranab Ranjan Sir, who has always been the cornerstone and who has been always supportive of our endeavors in ARC activities of EIZOC. Thank you so much, sir. For a purpose, he has a previous engagement, so he had to leave early. So it's the same with our secretary, sir, Dr. Soros Bhattacharjee, who had previous engagement, so they had to leave early. Thank you so much. Thank you so much. Nevertheless, last but not the least, I'd like to extend our sincere thanks to Anthod Pharma for supporting this program for so generously over this period of time. This is our eighth webinar, ARC webinar of this year. And Todd has been the one who has been providing this technical support and making this all feasible. Thank you so much, everyone, once again, for the wonderful discussion. And we had a pretty good, very good time, a very time well spent. Thank you so much.
Thank you, sir. Thank you.
Thank you, sir.
Thank you so much. And
Thank you all. Good night.
Thank you. Thank you, sir.
Good night, ma'am.
Good night. Good night, ma'am.
Good night, sir.
Thank you, Dada. Thank you, Dada. Thank you, Akbar, and thank you, Prasad.
Thank you, sir.
Thank you.
so much.
Thank you so much.
Good night.
Good night. Good night.